Hello, everybody.
I'm Dr. Marnie Fisher.
And I'm Dr. Elena Poulos from Kingsway Dermatology and Cosmetic Center. And we're here today to talk about skin cancer. It's a very important topic. And unfortunately, the incidence of skin cancer is certainly on the rise, really around the world, definitely here in Canada. So we're hoping today to talk a little bit about skin cancer, give you a little bit of knowledge, hopefully help you detect it for yourself, for your family members, people that you love, maybe some ideas about how we treat it and the approach to help put you really in control.
Broadly speaking, skin cancers are in two categories: non-melanoma skin cancers and melanoma skin cancers. Right. There are some other ones, but they're so rare that they really don't fall onto the radar. So those three categories make up almost all the cancers that are maybe 5 to 6 times the amount of, say, lung cancers that get dealt with in the country.
Right.
They're not recorded for various variety of reasons, but really quite prevalent.
Right.
Let's talk about the non-melanoma skin cancers first.
Yeah, and so, the reason is, so we've got the non-melanoma skin cancers over here, and then we have melanoma. And doctors, whether you're a dermatologist, whether you're a plastic surgeon that's operating on them, or an oncologist that treats them on the other end, and epidemiologists that track this data, those two groups are so different as far as how they present and what the overall outcome is that we think about them totally different. So we'll start with the non-melanoma skin cancer. So what we mean by non-melanoma skin cancer, the two basic ones in that category are basal cell carcinoma and squamous cell carcinoma. And they're extremely common. In fact, most patients with light-colored skin, if you've enjoyed the sun as a young kid, as a teenager, certainly in your 20s, as your skin gets older, we know that UV exposure over time causes mutations in the DNA. And as those mutations accumulate, it just sort of takes one kind of little flip of the switch and the tumor begins. So that's true of both basal cell carcinoma and squamous cell carcinoma. Mm-hmm. So why don't you tell us a little bit about what do they look like when they first appear?
Okay, so sometimes they're a little hard to detect. They can look like a tiny little pimple or a little red, pinky, scaly patch. But one of the key hallmarks is persistence. They persist and they'll still cycle through looking a little bit better, a little bit worse, a little bit better, a little bit worse.
But they don't go away.
Yeah.
And then sometimes they can even sometimes look a little bit crusty, right? So sometimes it'll look like a little pimple, but then people will say, oh, sometimes it's actually scabbed up a little bit or looks a little bit crusty even though I didn't pick at it. And then for some patients, actually, they'll start bleeding. And I think usually if you've got something like that that's bleeding, you'll know in your mind that there's something amiss and it needs to be checked out.
So sometimes I'll have my patients do the washcloth test, which is washcloth is very soft. You get your soap on it and you start washing your face. Normally, if your skin is very healthy, very strong, sturdy, intact, it's not going to cause any bleeding. But the skin cells in a basal or squamous cell carcinoma are going to be a little bit less connected, and they're friable so that you can almost pull them off with a washcloth. And I've had patients find their own basal cells.
Oh yeah, absolutely. And I think often what times is when people have had one, well, first of all, if you've had one, you're much more likely to develop more in the future. And that's really because all of your skin has really been exposed to the same amount of sunlight. And I think that for many people, once they've had one, they kind of know what to look for, and it helps them catch the second one. So then if we kind of dive deeper, so if we think about the difference between a basal cell carcinoma and a squamous cell carcinoma, number one, does it actually matter in how we treat it? And number two, do our viewers actually need to know what the difference is?
I mean, the answer to that question is a bit of both. It's yes and no. So the basal cell carcinomas are a little bit less aggressive.
Yes.
They tend to cluster in a little bit of a sphere or a group most of the time. There's a superficial variant as well. And they might grow a little bit more slowly. The squamous cell carcinomas can be a little bit quicker growing, a little bit more aggressive. They may, when they are tracking down in the skin, have what's called a tracking or a perineural involvement, which would be considered very serious, and it's treated very seriously.
Yeah, thinking about basal cell versus squamous cell, you know, what we often think about is there a chance that this lesion or this cancer hasn't metastasized, meaning has there been any component of this tumor which is broken away from the original site where it developed into other tissues? And although we know it can happen with both types of tumors, it's actually exceptionally rare for this to happen with a basal cell carcinoma. I think in my career, I've been a dermatologist now for over 20 years, I don't think I've had a single patient where I've had a basal cell cancer metastasize, lucky for me. Whereas squamous cell carcinomas, even though metastases are still quite rare, it does happen. So, and certainly there are certain areas where if we develop a squamous cell, we know the chances of metastases are a little higher. So for example, the lips would be considered a high-risk area. The ears are a high-risk area.
Down the center of the face, anywhere on the center of the face is high-risk area.
Yeah, they kind of look the same. Squamous cell grows a little bit faster. Squamous cell a little bit more likely to kind of get crusty and inflamed than a basal cell. But generally speaking, they're both treated the same way, which is the primary mode is surgical excision. So either with the dermatologist, or if they're larger, we'll send them to a plastic surgeon, or there's a specialized technique called Mohs surgery that we sometimes refer patients to if it needs to be removed under microscopic control. Occasionally, if it's a bigger lesion or if it's an area that cannot be operated on, we will recommend radiation therapy. I would say that's maybe 1 in 1,000 that would need radiation. Would you agree?
Yeah. Normally it's a bit more complicated area to excise. So due to the area itself, the size of the tumor, and the health of the patient, really. Yeah. And those patients do pretty well, actually.
They do.
Really
So
well.
by far and large, like most patients do really well. There's always a certain, difficult populations, and generally speaking, that difficult population. So people are on immunosuppressant medications for other diseases. Because their general immunity is down, the incidence of tumors for those patients is quite a lot higher. So those patients are typically the ones that we will follow a little bit more closely, a little bit more regularly, because we know it's actually very common for patients to get repeated new basal cells coming up and new squamous cell carcinomas coming up.
So let's talk a little bit about prevention. Are there ways to prevent skin cancer? Certainly there is, and the number one way is to protect yourself from this accumulative UV exposure that is in your face, on your neck, on your shoulders, on your back, and it starts as young as a baby.
Yeah.
And that damage, once it's set, it can be repaired. However, it travels forward, and then when it gets bombarded again and again and again with UV exposure, that's where we've got the mutations that add up. And with that combination of mutations, that gives the skin cancer. So I've seen skin cancers in as young as, say, patients who are 24, 25 for sure.
Yep, definitely. Yep. And I mean, really, we know that sun exposure is the #1 risk factor for these type of skin cancers. I mean, sometimes they can happen. Definitely, there's other type of skin cancers that we're not going to discuss here today because they're much more rare, where sun exposure is not a risk factor. But by and large, if people have been careful with their exposure over their lifetime, they haven't used the tanning bed, right? They haven't had a lot of sunburns, and the incidence is actually very low for those patients. Okay, so let's talk about the other major category, which is of course melanoma skin cancer. So melanoma, a super scary and upsetting disease. What should we all be doing?
It's up to the individual to know their skin, know their body, know where the moles are, the brown moles, what kinds of types of styles of moles that they have that's regular for them, doing the survey with mirrors, reflective mirrors, getting a partner to help, taking digital photographs to record some of those moles so they can look at it, 1 year or 3 years later and compare and say, oh, it has changed. And so knowledge of those moles and if they have changed or not, or detecting a new one is really the key. So early detection is really the key.
Yeah, exactly. So melanoma, right? And, even backing up to say, what does it look like? So melanoma, by and large, it looks like a mole that's gone wrong, right? So a typical mole, a regular looking mole, is usually a brown color. It's usually symmetrical, it's round, it's smooth, it's even. Typically, melanomas, because it's a cancer and the growth is uncontrolled, it doesn't have that nice normal appearance to it. So we call it the ABCDs of melanoma. So when you're examining your skin, you're looking for, so A standing for asymmetry, B for borders, so they have irregular sort of jagged looking borders, kind of like an amoeba as opposed to like a nice smooth circle.
I like to say the coast of Nova Scotia.
That's a good one. Yeah, that's a good one.
Sorry, Nova
So
Scotia.
C meaning for color, right? So is it all one color, or is it blotchy and irregular in color, or is there one spot that's like really dark? And even, let's say that one lesion, is there one lesion that looks like it's a lot darker than the rest of the moles on the body? So color being a little bit different. And then D standing for diameter. So over time, is that diameter expanding and is the mole getting larger?
The ugly duckling rule.
Right. Or which one of these is not like the other? That's what I say. When you're
Yeah.
looking all over, if they all look the same, then great, right?
Yeah.
You can be reassured. But if you see one that looks different, like this is not like the others, then you want to really focus and watch over time that and see, is it changing? Is it growing? Is it looking different? And certainly if a change is seen, it should be, you should really head to your doctor.
And then there's also the component of tracking digitally. So that is something that almost everybody can have these days.
Yeah.
And it's quite amazing how we forget and how that would jog our memory as to what things did look like even a short while ago.
Exactly. So, my approach to that depends on the person, but sometimes people will only have, let's say, 2 or 3 moles on their skin, right? And they'll say, okay, just take a photograph, right? I always like actually telling them to put a little ruler next to their mole so that you get an idea of the size. It helps put it in perspective. So take some photographs. Now, if people are covered, so, if they're covered in moles, so some people literally have hundreds, like all over their body.
That's a special case.
It's a special case, and there are certainly certain technologies that are available through a doctor's office, usually dermatologists, where there's special cameras that are used that can really get that high detail. And even more helpful is just tracking them in a computer software system so that you can see over time whether or not they've changed. How many people do you think really need to do those kind of special photographs?
Not very many.
Like less than 1 in 100, right?
Yeah.
Most of us have kind of normal looking moles, and just like a regular digital camera or your cell phone, if taken well, is enough to help you monitor it over time.
So,
Okay, so let's say you find the melanoma then, what would be the next step?
well, if you detect something that is suspicious or highly suspicious, you flag down your primary care physician and you say, this is changing. I'm very suspicious of this mole, and I think I want to see a dermatologist. I want to see a specialist to get a confirmation. Depending on the size and shape, you might be then referred directly to the dermatologist or the plastic surgeon for biopsy, excision, diagnosis, confirmation.
And
there's lots of different steps there.
Yeah.
And
the most important thing I would say is that really it's urgent. Right? So if you see a lesion that you're suspicious is melanoma, truly time is important. And so it's not something that you want to sit on. You don't want to procrastinate. You should be seeing your primary care physician right away. Your doctor will be able to know by looking at it either, hey, this is totally normal, or hey, you know what? I'm not sure. We certainly need a biopsy. Good thing you came in. Many primary care physicians can do the biopsy. Not everybody is equipped to do it in their office, so at that point you would get a referral. At our office, I can tell you we always recommend that we want to be seeing that from our primary care doctors that refer, hey, I'm worried it's melanoma, and we will fast track those appointments.
yeah, that's the most helpful communication to help the pathway for sure. Too often we hear patients who are waiting for a mole that is risen or raised up off the skin, or is symptomatic, like an itch, or has a sheer sign like bleeding. And those are definitely signs of melanoma, but that's late stage melanoma. And late stage melanoma is a little bit more aggressive, and can metastasize, and there are treatments, but it's more difficult.
Exactly.
Yes.
And we really encourage everybody, like now with the internet, honestly, it's amazing. So you could literally go online, look up images for melanoma, early stages, images of melanoma, late stages. You'll get dozens of photographs on your computer screen. It is a good idea. It takes 5 minutes to do it, and then at least you kind of have an idea of what you're looking for. I'm not saying that you got to wait until things look, terrible before you see your doctor, but it just gives you an idea. There's actually been a study that's shown that in general, people that find their own melanomas, in other words, they were attentive to their skin, they were looking at their skin, they're the ones that sought medical attention because of a changing skin lesion. Generally speaking, their prognosis was much better than those patients that waited and actually their doctor found the melanoma. So then really, we always encourage anybody listening to this video, spend a few minutes and educate yourself. So read some things on the internet. There's a lot of great websites, there's professional organizations, there's a melanoma network, lots of really great resources. And I always feel the more you know, the more empowered you are to take care of yourself and your loved ones.
Yeah, I mean, I had a patient experience just a little while ago where there was a mom and a daughter, and the daughter saw a spot in the crown of her head as she was in the pool in the summertime. And it turned out it was a caught early melanoma. And so that was just being observant and then suggesting and helping a loved one get some good care is very, very important. Yeah.
Great. How would you actually do a skin exam, right? So the way that I explain to my patients, it's sort of like doing a breast exam. We all know we should be doing this on a monthly basis. And if you're in the habit of doing it, and you're doing it regularly, you could actually save your life or save the life of a loved one. So my approach and what I recommend to patients is just have a systematic way of doing it. So typically, checking your skin once a month is great. You certainly do not need to do it, nor should you be doing it every day, but once a month is great. So if you have an online calendar, put it in as a recurring monthly event, right? Check your skin. It takes about maybe 10 minutes tops to do it. And then you want to do it in a systematic fashion. So my approach is start at the top. So you look carefully, your forehead, your entire face, you go down your neck, you do your chest, you do your abdomen. You should be looking at your genital area so you can use a mirror to get a better look. The fronts of your legs, down to your feet, your toes. You should be looking at the soles of your feet. And then when you do the back side, you can use the help of a full-length mirror behind you. So you have a full-length mirror behind you. You can sort of use a big light overhead, like a mirror overhead, to look at your entire reflection. And again, top down. So, the nape of your neck, your shoulders, the back, your buttocks, the back of the legs. And then also look at your arms, so the tops of the arms, the underside of the arms, the whole under area. And I think at the beginning, people often have a hard time because they don't know, is it different, is it new, is it weird? It can be very anxiety provoking. But as you do it month over month over month, you'll get into your habit, you'll have your routine, you'll start feeling, oh yeah, there's that same mark I noticed last time, but it's exactly the same. Or, oh yeah, there's that mark I noticed last time. I took a picture of that. Let me take a look. It hasn't changed. Okay, I feel great. So it's a good idea to do for yourself and also for your loved ones.
When I'm talking with my patients, sometimes I will say take a seasonal approach, which is about every 3 months. So in the super important context of finding something that is changing, I find that maybe a month to month is too early to find a change. Certainly, it might put a little stress on some of the patients who are a little bit more anxious. So I find that every 3 to 4 months, looking for those changes, as Dr. Poulos alluded to, is very, very important. But the systematic approach is always a good bet, for sure.
So thanks so much, everybody, for watching. We'll see you at our next video.